Right. With a short technical interruption, I hope we'll be able to sail the ship of pharmacology in the morning, and in the afternoon session we are going to have periodontics. One of the very good teacher, Dr. Shraddhanand, is going to review periodontics. So we have two kinds of sessions. One falls on Sundays, morning 9:30 to around 7:30 in the evening, and Monday to Saturday we have every day 5 to 8 p.m. Now the idea is preparing every day is much more a physiological phenomena rather than burning out only on Sunday. But at the same time, as the house surgeons, we get the time only to leisure time to attend on Sunday. That's the reason we have a combination of the two. So let's make the great beginning, doctor. Is the voice okay, Suresh? Yeah. I hope the online students also, the voice is loud and clear. Yeah. So today we'll review general principles of pharmacology. Don't worry, the notes is coming. They have given it for Xerox. Is the notes come? Please give them. General principles of pharmacology, autonomic nervous system pharmacology, non-steroidal anti-inflammatory drugs. These are the three important areas which are going to be the part of the today's review. What's your name, doctor? Huh? Pratyusha. We have Pratyusha and Gyaneshwari, Priyanka. We have one online Priyanka attending all the way from Rajasthan in Jodhpur, and we are also having the students who are accessing today's program from the home all the way as remote as Punjab. So the advantage is now broadcast to home. No need of travel, especially so in metropolitan cities. So let's make the beginning, but you need to travel because you will have privilege of a online class. So doctor, general principles of pharmacology. Huh? Already work on? Okay. Yeah. Now, there are about some 60 questions in general principles of pharmacology based on which we will have a review. What is the part of the prescription? As a doctor, as a dentist, we all write prescription, where the directions of the patient, including the dose and the method of administration, are basically included. So fundamentally, whenever you look at any prescription, there are various parts of prescription. Superscription, which means what is the recipe, phenobarbital, etc., etc. Subscription are the instructions that you give to pharmacist. Sometimes there will be catastrophic consequences which occur because of a bad prescription. For example, chloroquine. Chloroquine, which is a malarial drug, anti-malarial drug, very benign drug. But if you don't know what is the dosage for a pediatric patient versus the adult patient, Rajni, can you listen to the speakers so that if any problem is there, you can let us know. The voice for the online students, you can sit and listen. Is the voice clear? So subscription is information to the pharmacist. Can you please check the voice for the online students? Is it clear? Yeah? Yeah. Then we have the inscription, that is the medication which is being prescribed, and the directions for the patient is basically called signa, is what need to be remembered. So superscription, subscription, and inscription and signa. Subscription is the direction to the pharmacist about the ingredients of the prescription and recipe is what need to be understood. What is the grain in milligrams is an important MCQ. From where did we get independence? India. We got independence from Britishers. So whatever the system of the Britishers have left, pound is a Britishers word, kilogram is a Indian and American word. So you must know a gallon means 3785 ml. Similarly, 1 pint means 568 ml, and 1 ounce means 30 ml, 1 cc means 1 ml, and two common words which we use are called teaspoon, tablespoon in the prescription. A very common question which is being asked, is the voice clear for the online students? Yeah. 1 teaspoon is 5 ml and a tablespoon is 15 ml is what need to be remembered. Similarly, 15 grains is equal to 1 gram and 10 grains is 600 milligrams. 1 grain is equal to 64 milligrams. That is what we need to clearly remember. And a half grain is equal to 30 milligrams is what I want to underscore to all of you. Now doctor, for a 70 kg individual, the adult dose is say 100 milligrams. The question asked is, what will be the dose in a child who is weighing 90 pounds? Now the main challenge in this question is, what is a pound? Pound in terms of kilograms. Simple rule is, half kilo is a pound. 1 pound is equal to half kg. 90 pounds means how many kgs? Nearly around 45 kgs. Since 90 pounds is 45 kgs, if 70 kilograms require 100 milligrams, 45 kgs individual require simple mathematics. 45 by 70 into 100, which is 60 milligrams is what you need to fundamentally remember, doctor. Pessaries, they are the dosage forms of the drug in which mucosal site. Generally we use the word called vaginal pessaries. So one of the common high-yield issue for the examiner is routes of administration of the drugs is a very common topic on which questions come. So where do we use pessaries, doctor? Basically for any topical application into the vagina for a localized action, we use what are called as vaginal pessaries. Now, first order kinetics, zero order kinetics. What is the main difference between the two? To understand this is to understand pharmacology, at least pharmacokinetics. So what is the difference between pharmacokinetics and pharmacodynamics, doctor? Kinetics is what the drug, the body does, how the drug is metabolized in the body. What are the effects that the drug has got on the body, like the adverse effects, that forms the pharmacodynamics. So now let us talk about first order kinetics. There are basically two types of kinetics, doctor. Zero order kinetics, first order kinetics. Who is a zero order kinetics? It is like a government job. No job on Sunday. Monday to Saturday, you come to office at 11 o'clock and then you will have first call the home. I reach it safely and tell the wife, that you have reached safely. Sometime in the afternoon, you will take a short nap. By 4 o'clock, you are ready to go home. Whatever you do, there will be promotions. Whatever you do, there will be increment common to everybody. There is nothing like you worked hard or you worked less. Everybody will have increment, everybody will have promotion, ultimately you will retire and die one day silently in a burial ground and sent to burial ground. Drugs also, if a constant amount of drug is metabolized for every unit time, then you basically call it as the zero order kinetics. That means 100 grams became 95 grams. You have administered 100, a drug doctor, the blood concentration is 100 milligram per deciliter. That became 95 milligram per deciliter after 1 hour say. For the 95 milligram per deciliter drug after drug elimination to become 90 milligrams per deciliter, 1 more hour has taken. For the 90 to become 85, 1 more hour. 85 to become 80, 1 more hour. For every 1 hour, fixed amount is getting eliminated here. That is what type of kinetics called as zero order kinetics. What is first order kinetics? In 1 hour 100 became 50. Another 1 hour 50 became 25. 1 hour 25 became 12.5. 50% proportion is getting reduced for every 1 half-life. That becomes the first order kinetics, where a constant fraction per unit time is metabolized. What is the faster way of metabolism, doctor? If you are in a corporate job, it's faster to be promoted. You may start the life as a executive and you may end up in a managing director. That is basically first order kinetics. But what is the sad part of the story of the God? Most of the drugs in the therapeutic dosage follow first order kinetics. When they become toxic dosages and accumulate, you want a faster elimination or a slow elimination? Faster. But at that time they become zero order kinetics. The time when you want it to be fast, it becomes slow, and normally it will be fast. So that is the reason the drugs lead to toxicity is what need to be remembered. 5 to 6 points are commonly asked in entrance exam with regard to this kinetics. How is the half-life if it is a zero order reaction? With a decreasing concentration, half-life keep decreasing. Zero order is a slow way of elimination or a fast way of elimination? Slow way of elimination. When the concentration of the drug is high, half-life is longer. Is it not slow? If the half-life is longer, the elimination is slower. When the drug concentration is high, there is no echo or any problem. Absolutely, the voice is clear online. Anything into the chat window, please let me know if it is there. Whereas, when the drug concentration is becoming smaller, where you don't want a fast elimination, that time the half-life is become smaller. That means it is faster when the drug concentration is is low. That is the paradox about the zero order kinetics, is what you need to basically understand. So basically, if you plot the time against the concentration, what kind of graph you are getting? You are getting a straight line, and the slope of this graph is constant, so that the rate of elimination, if you look at the amount of drug eliminated, it is constant amount which is eliminated rather than proportion in zero order, is what need to be remembered. Suppose if you draft a graph where you took on x-axis time and the rate of elimination on the y-axis. Is there any change in the rate? The rate is constant and hence the slope is 0 in case of rate to time graph in case of the zero order kinetics. How is the first order kinetics? Whether the concentration is high or whether the concentration is low of the drug, half-life remains the same. The length of the half-life is constant. And if you happen to plot a graph of the rate of elimination versus concentration, rate is proportional to the concentration for the first order reaction is what need to be remembered. So this is a very important point to be appreciated. Now doctor, what is the confusing thing about this? I know what is the confusion that will be there in the mind when we go to exam. Zero order means constant amount eliminated. First order means it is the constant proportion eliminated. We use the word constant for amount and proportion when it comes to zero or first order kinetics. But when we talk about half-life, is half-life constant in case of zero order kinetics? No. When the concentration of the drug is high, half-life was longer. That means elimination is slower. When the concentration of the drug is less, the half-life is shorter and the elimination is faster. That is what you should not forget. Whereas in the case of the first order kinetics, what's happening? The rate of elimination, don't confuse it with half-life. Rate of elimination is proportional to concentration of the reactant. So how is the concentration? Suppose concentration is high. How is the rate of elimination? Don't confuse this with half-life. I have plotted this graph between concentration and rate of elimination. So when the concentration is high, rate of elimination is high. Right? When the concentration is less, rate of elimination is less. Hence, when the concentration is high, when the drug is concentration is high, the rate being faster makes the first order kinetics a faster way of drug elimination from the body is what need to be basically remembered. So this is the whole story. Now doctor, if you take any drug, what is the most important factor that decides the rate of elimination of a drug? Every drug is cleared by various organs. Some drugs are cleared by kidney, some drugs are cleared by liver, etc., etc. So the clearance of the drug by a particular organ is an important determinant on the rate of drug elimination. You followed my point? So, if you take most of the drugs, how is their clearance basically? The clearance is constant. So that is the reason the rate of elimination is not saturable. And the rate of drug elimination is only dependent on the concentration of the drug. It doesn't depend on the clearance, because clearance is constant. If you take most of the drugs, the liver will not say, since it is 7 AM in the morning, I don't want to work and I will not clear the drug. Because it is 8 PM, I have to go home, that's the reason I will not clear the drug. Will the liver or kidney will say like that? They will not say, for you took a paracetamol doctor, or you took a propranolol, or any drug. Where it is morning, afternoon or evening, the kidney and liver will be clearing the drug constantly. That is the reason the rate of elimination of a drug is purely dependent on the dosage you took and the concentration you have built in the plasma. If it is a higher concentration, it takes a little longer for it to be eliminated. So it is not dependent on the liver or kidney, and it is not dependent on the enzymes in the liver or in the kidney. So what is the important rule? In most of the general circumstances, clearance is constant over a concentration range, elimination is not saturable, and the rate of elimination is only directly proportional to concentration. That is what you need to basically remember. Now let us see. You have taken a drug which is about 500 milligrams. The moment you administer the drug, what will happen? Drug has two choices. It can remain in plasma or it can diffuse into the tissues. Right, doctor? Unless it is in plasma, it can't reach the organs, liver or kidney. Unless it reaches liver and kidney, it can't be cleared. So that is the reason whenever you administer a drug, the most important determinant factor is whether it is remaining in the plasma or whether it is getting distributed. If it remains in the plasma, it will reach the kidney or liver, the organ of elimination. Once it reaches that organ of elimination, how well it is cleared by that organ of elimination, clearance, is the ultimate determinant. So these are all the various factors that decide the drug clearance. So doctor, now I'll ask you two questions. Most of the drugs, most of the times, whenever we administer the drug, they follow zero order or first order. What is your answer? They follow first order kinetics. First order kinetics is what you need to remember. And whenever the clearance is first order, whenever the kinetics are first order, what is the way you can calculate the clearance of a given drug? There should be some method to know, is the liver working, kidney working, how is the clearance of a given drug? So how can we be able to calculate that? For that we need to plot a plot called as concentration time curve. You take the plasma concentration and you plot how is the concentration changing over a period of time. Once you administer the drug concentration will reach a peak value. That is the time which is called as time of absorption. After that, what will happen? The drug typically become cleared from the body and the drug concentration starts to fall. So what do you get when you plot the concentration against the time? You get a curve called AUC curve, area under the curve. This area under the curve is an important indicator of the clearance. If you can calculate the area under the curve, you are indirectly calculating the clearance of that particular drug, is what you have to basically understand. So doctor, you have administered a drug. It took a little longer time to clear and it did not reach a very high peak in its peak concentration. Even before it has grown big, it was killed. It reached only 30 years of life and died. Another drug, it has reached a higher concentration and ultimately has fallen down. So in this case, the area under clearance is 2 into 3 is equal to 6. In this, the area under curve is 3 into 3 is equal to 9. So which drug has a higher clearance between the two? The drug whose area under curve is higher is the one which typically has got a higher clearance, is what you have to basically conclude. So whenever you draft a area under the curve plot, the initial part is because the absorption of the drug where it reaches the peak concentration. The second part is due to the elimination, is what you have to ultimately understand. So that is the story of clearance. You calculated clearance. Is there any way to calculate the rate of elimination? Rate of elimination, yes. The drug will achieve certain steady state concentration or peak concentration. It is able to reach, no? That concentration of the drug into the clearance which is calculated by the area under the curve will give you what is called rate of elimination. So these are the important formulas which you have to basically remember, doctor. You're all given the pharmacology notes, okay? But this explanation crap is available in every textbook. First, hence we have given only the questions. Are you able to identify where is the pharma notes in that? Yeah. Is it pharma or orthodontics notes? Pharma. Okay, good. Now, doctor, if you take a drug, one of the common MCQs asked in the exam is, will the dose of the drug decide the half-life of the drug? For example, you took 100 milligrams of drug, taken a 100 milligram tablet. You took a 25 milligram tablet. When you took 100 milligram tablet versus 25 milligram tablet, what is going to be half-life? For a 100 milligram tablet, let us say it achieved 100 milliequivalents per liter. Just I am giving some empirical figures in the plasma concentration. For that 100 to become 50, the time taken is called half-life. If you took a 25 milligram tablet, for the 25, let us say it achieved 25 milliequivalents plasma concentration. For 25 to become 12.5 milliequivalents, the time taken is called half-life. Will this half-life will be different if the dose of the drug taken is different? Is the question of the examiner. What will be your emphatic answer in the tomorrow's exam? The half-life of a drug does not depend on the size of the administered dose. Administered dose can be anything, but the half-life will be the same, is what you have to basically remember. Now, doctor, how are the drugs eliminated? We have a method called capacity limited elimination. So what is meant by capacity dependent limited elimination? Basically, let's say liver or kidney is eliminating a drug. How is it eliminating the drug? For example, it is using some enzymes to metabolize the drug. Then on what factor will then the drug elimination become dependent on? How that enzyme in the liver or kidney is working, right? Such an elimination which is dependent upon the saturable dose or concentration dependent form of elimination mechanics is called capacity limited elimination. Why? Because if those enzymes are deficient or if those enzymes are saturated, the drug is no more metabolized and it is not cleared. Hence it is called capacity limited elimination. The other type is what? No enzymes will modify, let us say, a particular drug. They don't biotransform the drug. Then the drug automatically get eliminated without any pharmacological modification. Then is it saturable kinetics? Will it work? Will they work then? No. When will saturable concentration dependent kinetics will work? If the drug elimination is dependent on certain set of enzymes in a given organ. If it doesn't depend on the enzymes, simply if the blood flow goes to that particular organ, then the elimination, if it occurs, then it is not a capacity limited elimination. So what are the keywords you will remember? Saturable dose or concentration dependent non-linear form of elimination is called capacity limited elimination, is what you have to basically remember. So once more we will come across this kind of kinetics in biochemistry. In enzymes chapter, competitive inhibitors, non-competitive inhibitors, there we will review it once more. For now, remember, capacity limited elimination is enzyme dependent saturable form of an elimination is what need to be remembered. But now let's go to the next important issue. What drugs in the body, favorite MCQ in exam, are typically capacity limited saturable form of elimination kinetics? 3 drugs. Ethanol, suppose you drink alcohol. What is the fate of that alcohol? How the body gets rid of that all beer and whiskey you have drunk in the night party? Alcohol is metabolized by an enzyme called alcohol dehydrogenase. That forms, alcohol becomes acetaldehyde. Acetaldehyde is converted in turn into acetate, acetyl-CoA. That's how it gets basically eliminated. Acetyl-CoA is the precursor for ketone bodies. So if you drink too much alcohol, you are producing too much acetate, too much acetyl-CoA, too much of ketone bodies. Okay? So I will anyway come back to the ketone bodies in biochemistry. If you are purely preparing for the state MDS entrance, the weightage of pharmacology is only 6 marks or 5 marks. But you go to AIIMS, All India Dental Exam, or any of the central institutes, it definitely carries about 10 to 12 marks. So that's the reason you need to be absolutely good with pharmacology. Anyway, you will be good with dental subjects, I believe. Even if you are less shining in dental subjects, we have got wonderful teachers who will shine you better in the dental subjects. Okay, they'll remove all the granulation tissue in the brain. Okay, doctor. Now, let's talk about pharmacology. What are those 3 drugs? What are those 3 drugs? Which are basically capacity limited, enzyme dependent, saturable kinetics. Ethanol, phenytoin, aspirin. Phenytoin, why do we use, doctor? Phenytoin, phenobarbital are all anti-epileptics. Aspirin, for everything you use aspirin. A pregnant woman gets eclampsia of pregnancy, we use aspirin. Headache, we use aspirin. Aspirin is like universal drug of Granima. Ethanol, entire world is running because of it. All election campaigning is running because of that. So you need to remember these 3 important drugs. Now doctor, where do we see zero order kinetics? Another way of asking the question. Now you understood there are 2 forms of kinetics. What are they? Capacity limited, saturable, enzyme dependent, concentration dependent kinetics is called first order or zero order? Is called, come on, zero order. Right? If you would have said first order, I would have walked out. The other type is non-saturable, non-drug concentration dependent, constant half-life wala kinetics is first order kinetics. Zero order kinetics, you will only remember 3 drugs. What are they? Phenytoin, ethanol, aspirin. So where is the answer? Zero order is phenytoin is what need to be remembered. So zero order is capacity limited elimination, ethanol, phenytoin and aspirin. And how is the half-life in this? Half-life will be more when you don't want it to be more when the concentration of the drug is high. When the concentration of the drug is high, you want half-life to be shorter for elimination. But in zero order kinetics, what will happen? Since all enzymes are saturated, elimination becomes slow, half-life becomes long. And when the drug concentration is less, when you want drug to be slowly eliminated, that time all enzymes are unemployed. So that is the reason elimination is fast and half-life is smaller. That is zero order kinetics is what need to be remembered. Because in first order kinetics, half-life is constant. Whatever be the dose taken or drug concentration, and proportionally drug will be falling down, not fixed amount. That's the point to be appreciated, doctor. A drug is administered in multiple doses. The dose interval is equal to its elimination half-life. The number of doses which are required for the steady state concentration of the drug to be achieved is how many half-lives? Did you understand anything of this? What are the new words? Dose interval. What is dose interval? The interval at which the dose is administered is dosing interval. TID, QID, BID. We use in the hospital prescription, no? That is all dosing interval. The dosing interval is equal to elimination half-life. The elimination half-life means the time taken for the drug to be eliminated to 50% of its present concentration is elimination half-life. So what you are doing for a drug to become 100 milligram to become 50, 50 to become 25, 25 to become 12.5, let us say it is taking every 8 hours. Same time you are also giving every 8 hourly that particular dosage. That is called dose interval being same as equal to elimination half-life. In that scenario, the question asked is, when you are doing like that is drug is getting eliminated and you are administering the drug at frequent intervals. In that scenario, how many doses are required for the steady state concentration to be achieved is the very important question. Very simple. Now tell me, suppose for every elimination half-life you are once more administering the dose, will the plasma concentration keep increasing or will it keep decreasing? You coolly listen to my question. For every elimination half-life, if you are administering the drug, with every elimination half-life, what is happening to the drug concentration? It is falling to half. But are you letting to fall? You are once more administering the given dose. Once more it is rising. One elimination half-life once more happened. Once more it want to fall. But once more you are administering the full dose. It is like preparation for entrance exam. You have read for 1 week seriously. After that, you are trying to forget. And we are conducting the Sunday day-long brainwashing class. Then once more your memory improved. Once more as the week is passing, there is a elimination. So when you are doing it constantly, after about 8 to 10 weeks you will understand, though I am reading on Sunday and want to forget it by next Saturday, I am not permitted and once more Sunday we revise a class. So ultimately at the end of 8 to 10 classes you will remember, oh, I read a lot of things for the MDS preparation. And you reach a point of a good amount of background knowledge. Then that impact factor of having had attended coaching will then appear in your brain. So that's the point. You got the elimination half-life funda now? That's good. After 3 half-lives, please give the doctor the notes. With each half-life passing, if you are re-administering the dose with every elimination half-life, the plasma concentration is not permitted to fall down. And what will happen after 3 elimination half-lives? It will reach 87.5% of its peak drug concentration. Right? After 4 half-lives, 4 elimination half-lives, with every half-life if you are re-administering the drug, it will reach 93.7% of the ultimate steady state concentration which it will reach. After 5 half-lives it will reach 96.9% of the steady state concentration it will reach. Right? When is the entrance exam? All India dental exam is in? All India dental exam is in the month of January, right? Every week on Sunday day long you are preparing, Monday to Friday also you are attending the classes, you are constantly solving the mock tests and attending discussions on the mock tests of subject test and Sunday test. After about 10 to 12 weeks you reach a steady state concentration. Nobody will let you fall. You reach a certain abundance of the concepts in your mind. It's like kite flying. Do you know kite flying? Initially kite you are worried, will it stick to that pole or this tree or that way. After the kite goes a little bit high, even unless you drag it down it won't come. That is what happens with the drugs. This is a favorite MCQ in the exam, doctor. How much of percentage of the steady state concentration is achieved with every passing elimination half-life? With 3 elimination half-lives 87.5, 4 elimination half-lives 93.7, 5 elimination half-lives 96.9 is what need to be remembered. And with the first dose it reaches 50%, second dose it reaches 75%, third dose it reaches 87.5. I told third dose is 87.5, 93% with fourth dose and 96% of the fifth dose. That's the reason. What is the correct answer? When will it reach the optimum steady state concentration? After the passage of 4 to 5 elimination half-lives is what you have to ultimately remember, doctor. So if you are giving repeated fixed dosing at intervals equal to half-life, the concentration curve, it want to fall, it is made to rise. It want to fall, once more you have given dose. And ultimately it will reach the peak steady state concentration at the end of 4 to 5 elimination half-lives is what you are going to ultimately remember. Now, doctor, we come to a important area. See, pharmacokinetics is the only nasty part of pharmacology. You understood that? You understood a significant part of it. Okay, doctor? To sit for a long hour of a class, are we used to it, or have we lost the habit of it? You have lost the habit, I believe. Am I right? Huh? Yeah, it's a question of stamina. Day long Wimbledon. For a period of time. The point is, if you are taking, see, at the end of around 5 hours, you are able to finish around 2 to 300 high yield facts. Totally pharmacology require 20 hours of review. Once you have reviewed 20 hours, around 900 questions are there. Any exam you go, the questions are asked only from those set of 900 questions. But you should understand them conceptually. Then you will remember it long run. Okay, doctor? So just bear with me. The moment you want a break, please let me know so that we'll fall for a cup of coffee. Now, bioavailability. What is the meaning of it? Whenever you give a drug, it is like a central government fund. Prime Minister declares 100 crores. By the time state government receives that 100 crores and tell it has received only 50 crores. And from the 50 crores, by the time it reaches to the local MLA, it will become 10 crores. Local MLA will say, oh, where 10 crores? Too much you are talking. Only 10 lakhs I received. Ultimately, when it is being spent, it is only 1 lakh. When you take a drug also, the amount of, the fraction of the original dose you have taken that comes unchanged into the ultimate systemic circulation is basically called bioavailability of a drug. Suppose you inject a drug intravenously, you have 100% bioavailability. If 100 crores of the central government is directly brought to the Panchayati Raj office, it remains 100 crores. But it has to pass through various steps. So, bioavailability is that ultimate amount of the drug that is reaching the systemic circulation. Now, if you give intravenously, 100% is the bioavailability, and in certain routes of administration you may have ultimately 0% of the drug reaching systemic circulation. For example, you take a asthmatic drug, it is a local bronchodilator of the bronchi. Will it go into systemic circulation? It won't go at all into systemic circulation. So its systemic circulation reach is 0. You took a tablet of nitroglycerin. There is a strong metabolism of the nitroglycerin. Once you have swallowed the nitroglycerin, it enters into GIT. From GIT through portal circulation, it will go into liver. Liver metabolizes it. So that from the liver, through hepatic vein, it comes into IVC and enters into systemic circulation. By the time it reaches systemic circulation, liver almost half of it has snatched it. So that is called first pass metabolism of any given drug. So there the bioavailability decreases. But if you have injected directly any drug into the plasma, then the bioavailability is 1. So what is the favorite MCQ of the examiner? Bioavailability of a drug ranges between what to what value? 0 to 1 is what you have to basically remember. Now doctor, what are those drugs which are known to have a significant amount of first pass metabolism that lowers their bioavailability is a very important question. Propranolol, which is an important antihypertensive, 26% bioavailability only, because 75% of it is metabolized by the liver is what need to be remembered. Morphine, very common painkiller and also a drug used to treat pulmonary edema. It has only 30% bioavailability. Are able to, online students are able to listen? Huh? Broadcast is clear? Okay. 70% is metabolized by the first pass metabolism is what need to be remembered. I think Rajni, you can leave. Huh? Yeah. So nitroglycerin, you have two methods of administering. You can give it sublingual NTG or you can be able to give it like an infusion. So nitroglycerin also, if you don't give sublingually, rather you take orally, high amount of first pass metabolism. So three common drugs: morphine, propranolol, nitroglycerin is what you have to basically remember. Now doctor, what variables decide the bioavailability of a drug? Obviously anything that metabolizes a given drug before it goes into systemic circulation will affect its bioavailability. Suppose if you have taken grapefruit juice, what it will do? It will destroy the P450 enzymes. P450 are the enzymes which metabolize a drug and decrease bioavailability. But if you have taken grape juice, those P450 enzymes are inhibited, so the drug is not metabolized, so more amount of it will reach unchanged into systemic circulation. So that is the reason the bioavailability will improve. So grape juice, the drugs which induce glycoproteins, P-glycoproteins, rifampicin, one of the anti-tubercular drug, it's a strong inducer of the P450 system. So will it increase or decrease bioavailability? It will decrease the bioavailability. The drugs that inhibit the P-glycoprotein, like the cimetidine and fluoxetine. Fluoxetine is a antidepressant called selective serotonin reuptake inhibitor. Don't worry about what it is, but remember it is an antidepressant. Cimetidine and fluoxetine, they are the inhibitors. And any liver disease, as in cirrhosis, which destroys the liver, even if the drug goes to liver, it is no more metabolized. So more amount of it become available to the circulation and bioavailability will increase. There is a reason what will happen in a liver diseased patient. Suppose if you happen to give a drug whose metabolism is dependent on the liver, the drug levels of that particular drug will increase to toxic proportions, and that will lead to development of drug toxicity is what you have to basically remember. So summarize doctor, Bioavailability, how do you define? The fraction of the drug that is ultimately absorbed into the systemic circulation is basically called as the bioavailability, is what need to be remembered. Now doctor, how will you calculate? Bioavailability is an important question. Very simple. You administer the drug intravenously, right? When you administer the drug intravenously, what happens to the drug concentration? It will reach a particular peak value. Immediately as you administer, it reaches peak. There is no waiting. And slowly it keeps falling. So if you take plasma concentration of the drug versus time, you get one curve, which is called the curve which we got when the drug is administered intravenously. Then you administer the drug orally. It takes some time to reach the peak because it is the phase of absorption. Then it will take some time to fall down, that is the time of elimination. Then you got one area under the curve which is oral curve. So bioavailability is the area under the curve when you have orally administered by area under the curve when you have intravenously administered into 100 will give you the bioavailability of the drug is what you have to basically remember. So common MCQ asked in the exam is, when is the bioavailability? 100%. What is your answer? When you have intravenously injected. Now doctor, the drugs exhibit first pass metabolism. What is the exception? This is one of the previous AIMS MDS entrance question. Already we said zero order kinetics means only 3 drugs you will remember. What are they? Morphine, nitroglycerin, propranolol. These are the 3 important drugs to be remembered. First pass metabolism. Salicylates doesn't come under. Okay. So if you happen to ingest salicylates means aspirin, acetyl salicylic acid. It is absorbed rapidly, mainly in the upper small intestine, and you find the drug in plasma in less than half an hour. So that is the story of salicylates. There is midazolam, nifedipine, morphine, meperidine. These are all the drugs which have an extensive first pass metabolism. This list you need to remember. Tell me, what is midazolam? Midazolam is a benzodiazepine. Alprazolam, midazolam, diazepam, they are all what? Benzodiazepines. Meperidine, opioid. Nifedipine, calcium channel blocker. Morphine, which is used for treating pulmonary edema and pain. These are all the drugs which have high first pass metabolism is what you need to remember. So with most of the drugs, including the morphine, the first pass metabolism is very, very high, so that the orally administered drug reaches the systemic circulation very less. That's a point to be appreciated. And the bioavailability, if you take the morphine, is less than 25%. Only 25% reaches the systemic circulation. Now nitrates, they have a high first pass metabolism. What is the reason? The liver is having an enzyme which is called nitrate reductase. The nitrate reductase rapidly metabolizes the orally taken nitroglycerin, hence its bioavailability is very less. Whereas if you use sublingual route, directly sublingually your blood vessels are there, so it enters into systemic circulation. Bioavailability will improve is what need to be remembered. Now the next favorite question of the examiner is, after you have given the orally administered drug, the amount of the drug reaching the target tissue, how will you be able to calculate? Already we know, area under the curve, AUC is an important way by which you can be able to calculate the bioavailability of a given drug. Okay, doctor? Now, for a drug to be absorbed by a cell, obviously the drug need to cross the plasma membrane. It has to enter into the cell. and there it has to show its effect. One way to look at it. Second way, the drug is passing through the renal tubule. It is trying to go into urine, but in renal tubule what happens? Reabsorption occur. For the reabsorption to occur, what should the drug should do? It has to travel across the plasma membrane back into the plasma instead of going out in the tubular fluid into the urine. Favorite question of the examiner is, what factors are going to decide this diffusion of the drug across the membranes? Is a very important question to be understood. The general rule is, any drug which is water soluble, which is polar, which has a high molecular weight, it cannot easily cross the membrane. The converse statement of that is, a drug which is lipid soluble, which is non-polar with a low molecular weight, can cross the biological membrane very easily, is what need to be remembered. How will you remember? Water soluble drugs are not cannot easily cross plasma membrane. If a drug is water soluble, the cell membrane is lipid bilayer. How can water cross ghee, lipid? It can't. So it should be lipid soluble, not water soluble. If a drug is of a high molecular weight, a fat man with a fat wife with 4 fat children have to catch a bus means very difficult. And that too, a nagging wife who is packing extra 5 bags of luggage. High molecular weight cannot cross. A bachelor who is dating, who want to elope, zoom can start, but the same guy will become high molecular weight later on time as the age crosses, right? So water soluble, polar, high molecular weight cannot cross, you will remember. But here the fix is, commonly what students forget in exam is, polar hai to, can it cross easily or it cannot cross easily? Examiner to remember is the challenge. Generally in exam hall what we will think, oh, polar means ionic, ionic means electrical charge means more attractive dragging force means it can cross easily is what we will wrongly think. But polar, ionic state cannot cross. Cannot cross. Easy to remember is, rules are for fools, you remember. P is what? Polar, no? P is passport. If you have passport, generally you can pass the country. But in drugs case, you cannot pass. If there is no passport, you can pass. Because the rules are for fools. So, some way to remember. Okay, doctor? Now, what decides whether a drug is ionized or polar is one and same. A drug which is polar means it is ionized. A drug which is non-polar means it is non-ionized. Simple. If you take a drug which is acidic, if it is in a acidic environment, it is unionized. If it is unionized, then it is better absorbed. So, stomach is acidic environment or a alkaline environment? Acidic environment. So, all acidic drugs are absorbed in the stomach. All drugs which are alkaline, when they go to small intestine, they are non-ionized. When they are in stomach, they are all ionized. When they are ionized, they cannot be absorbed. But when they are non-ionized, when they go to the intestine, alkaline drugs I am talking about, then they can cross the plasma membrane is what need to be basically remembered. So, doctor, any drug, for it to cross, what is the determining factor? Polarity. Non-polarity is an important condition required for a drug to cross the plasma membrane. Second factor, Is it bound or unbound to the protein? All drugs are not strongly bound to the protein. All girls and boys are not always married. But all girls and boys are not attachedly married. Few people are very attached in a relation, few people are too flying away in a relation. So, drugs also are like that. Suppose if it is protein bound drug, when the other compartment says let us date, what it will tell? No, I already have a boyfriend, I can't come with you. But if it is a unbound drug to a protein, no boyfriend, no girlfriend, any day available for any dating. So that is what happens for the drugs also. So summarize, doctor, how strongly a drug is bound to protein, how ionized is a drug, how small is a drug, how lipid soluble is a drug. There are the 4 factors that decide the drug's transfer across the plasma membrane is what need to be remembered. What are the means by which a drug action typically become prolonged? Now you can easily answer this. How much protein binding is there? What is the rate of metabolism? And how is the renal status, which is the main organ of elimination? There are all the factors that decide whether drug is going to be eliminated or the drug is going to be retained in the body, and accordingly whether the action become prolonged or whether the action become shortened is what you have to